Okay, so I am so excited to welcome all of you today to our first in a series of Lunch and Learns called Visions and Solutions because at the Health Coalition, we believe that our healthcare system needs big visions and some practical solutions in order to move forward. And so today we're kind of kicking off a series with a deep dive in community-driven solutions. So thanks for being here. I wanted to start by acknowledging that I am calling in today from the unceded and occupied territories of the Musqueam, Squamish, and Tsleil-Waututh nations, who are part of the Coast Salish peoples in what's colonially known as Vancouver, BC. And I say that also acknowledging that I think many of us are joining from other parts of Turtle Island, um, and as a way to remind myself that our healthcare system has been very much shaped by colonialism and continues to be so, and that colonization is an important social determinant of health. So as public healthcare advocates, we like to brag that in Canada, our healthcare system is based on need and not the ability to pay. But of course, the ability to pay is not the only barrier to equitable access. And so colonization, racism, Indigenous specific racism, and many others are continue to be barriers to equitable healthcare. So we'll be digging into some of those barriers during the series in different ways. But today I'm really excited to start about talking about community governance and community-driven solutions because to me that's a meaningful way that all residents of BC can have meaningful voice in what our healthcare system looks like. So we'll get a chat more about that. Um, I mentioned that this meeting is going to be recorded, and I'll just reiterate that you have permission to turn your video on or off, or rename yourself if you don't want if you're concerned about your name appearing on video. And feel free to send me a direct message in the chat if you also don't want to send a public chat message to everyone. But this will be posted publicly as a learning resource for the rest of our membership. So I'm going to just share my screen briefly. Here we go. And just in case anyone here is not familiar with us at the Health Coalition, I'll give you a bit of a intro recap. So our mission is to defend our healthcare system against privatization or sources of profit making. We work to expand Medicare and improve access to quality healthcare for all. So that means expanding Medicare to cover things like pharmacare, dental care, one day public mental health care, and many other things, advancing evidence-based public solutions on healthcare issues. And that's really what we're doing here today is we're talking about what the evidence says are good public solutions to improve our healthcare system. We have kind of three areas of work that all of this work falls into: anti-privatization, seniors care, and primary care reform, which is kind of where this conversation today fits under. And I just also wanted to say that in the upcoming webinar series, you'll have to stay tuned for the dates and the topics as we kind of get the speakers organized and confirmed. But we'll be covering all of those pieces of our work in some ways. So where we're heading today, we're excited to welcome some great guests and friends among us. So we'll have kind of our main keynote guest presentation by Tara from the Our Care Project, which is a national study about primary care reform that we've been following quite closely here at the Health Coalition. And I'm excited to learn more about that. And then I invited Catherine Ah from the BC Association of Community Health Centers to give us a quick recap of what's a community health center, because we're going to really zero in as one of the models for community governed primary care. And I hope that Catherine's presentation can help us be on the same page, but also that she can point you to some other resources if you ever want to learn more about this really amazing model. And then we have two guests with us, Barbara Wood and Masoud Rahmani, who are respectively on the boards of their community health centers. And I'm really excited to get to hear from people who do this work of community governance and have some personal experiences to share about what it looks like to do that in practice. I'll invite you to visit our website, bchealthcoalition.ca. You can subscribe to updates, which is going to be important if you're interested in what the next in this Lunch and Learn series will be, when and what. You can sign up to volunteer or to become an individual organizational member. And of course, you can donate to our work. So I think that's it for me. I think I'm going to, without further ado, hand it over to Tara, who's our first speaker. And so Tara will speak, and then we'll go through the speakers, and there's going to be, I hope, at least 15 minutes for open Q&A at the end. So feel free to use the chat throughout to post questions, and we won't answer them in real time, but that'll help us kind of plan ahead for the Q&A portion. Over to you, Tara.
Thank you so much for that introduction, Audrey. And it's like a real pleasure to be here today. I'm calling in from Toronto, which for thousands of years has been the traditional territories of the Huron-Wendat, the Seneca, Mississaugas of the Credit, and many other Indigenous populations, and continues to be the home of many First Nation, Inuit, and Métis. I'm grateful to live and work on this land. Thank you for having me today. I'm excited today to share with you some of the work we've been doing over the last 18 months, and to really share with you what we've heard from our consultations with people across Canada. Over 16 months, we conducted what I think is the largest public engagement ever on the future of primary care in Canada. We heard from nearly 10,000 people across the country about what their experiences are, but more importantly, their hopes and aspirations, what they want to see in a better system. Together, these people spent like close to 10,000 hours with us, doing everything from a survey to active discussions. And what you'll see as I present this is that despite the diversity of people we talked to across the country, they really did speak with one voice about so much that they shared and what they thought was important for us to move forward with. So let me tell you a little bit more about our care and our process. It was an initiative done in 3 phases, 3 parts. It began in the fall of 2022 when we launched a national survey where we heard from well over 9,000 people across the country. We've actually posted all of the data from the survey publicly, so you can go to data.ourcare.ca and actually play a little bit with the data tool we have up there, see the answers to several questions from everything from, do you have a family doctor? How long does it take you to get in if you have an urgent issue? Do you use walk-ins? What do you think of like different ways of doing care? What kind of virtual care, like what kind of care is important to you moving forward from a virtual perspective, and more. So take a look at some of our data there, and you can also contrast not just what everybody thinks, but you can look at what people from BC thought in relation to people from Ontario or other parts of the country. But other people have done surveys too, and although our survey I think was really robustly done, the parts that I think actually make our care most interesting are the conversations we had with people across the country. So our second phase are something we call priority panels, and we did 5 of these, 1 in each of the 5 provinces of BC, Manitoba, Quebec, Ontario, and Nova Scotia. Did I say Manitoba? So BC, Manitoba, Ontario, Quebec, and Nova Scotia. And basically, in each of those provinces, we randomly selected about 35 individuals who roughly represented the demographics of the province. These were people who had volunteered, and among a large pool of volunteers, we randomly selected them. And they ended up spending 30 to 40 hours together, strangers who'd never met each other. And what we did is, first off, took some of the beginning parts of that time to really educate folks about primary care. We had many guest speakers, more than 75 across the country, who donated their time to help put people through, a curriculum of what primary care is all about, help to answer their questions. And then so much of the time was actually spent between people talking to each other, these strangers talking to each other, to really come to consensus about the top issues they felt were important to address, and recommendations for how those issues could be addressed. And at the end of the process, each of the panels wrote their own report, which we have up on our website. So if you're interested, I can point you to those at the end. So those were really in-depth sessions, and what was phenomenal about them is that not only did we see consensus within each provincial panel, but when we start to look across the panels, we see consensus emerge as well. But we knew those first two phases were leaving out some important voices, voices of people we know are underserved and actually more likely to have poor outcomes because they don't have access to healthcare and because of other barriers they face. And so our third phase of Our Care was really designed to put those voices front and center as well and hear from them. And so we did a series of 10 community roundtables. Each was about a day in length, sometimes split over 2 days. And they were all done in partnership with community organizations who had existing strong relationships with marginalized communities. In BC, you'll see that we did two. We did one with the group Disability Without Poverty, and we did another one with the Umbrella Multicultural Health Co-op, which I'm delighted is sharing the hour with us today. And then you can see some of the other groups that we engaged across the country here. And as I mentioned, I'll say that, despite the diversity of the people we heard from, they really did speak with one voice around what their vision was for primary care. We've summarized what we heard through all of the process in our final report, which we released at the end of February and is available on our website at ourcare.ca. It was pretty clear that everyone felt that everyone deserved access to high quality primary care. But to say that one statement, I think, is not providing the detail or nuance that's really needed for us to build that better system. And so what I'd like to share with you today is something that we call the Our Care Standard. 6 simple statements that really succinctly kind of summarize all that we heard from our many consultations, from the 10,000 hours, the nearly 10,000 people, what it is that people want to see in that better system. And so I'm going to take you through the 6 standards, but really focus in on the 6th and final one, which I think is the focus for today's session. The first standard is that everyone has a relationship with a primary care clinician who works with other health professionals in a publicly funded team. So this calls out the really important concept in primary care of a continuous ongoing relationship. But it also calls out that we need to expand and scale up team-based care, and that all of the care does need to be delivered within the publicly funded framework. People shouldn't have to pay privately for something as essential as primary care. The second standard is that everyone receives ongoing care from their primary care team and can also access their team in a timely way. So it holds these two concepts at the same time, that care should be both timely and ongoing or continuous. It's not one or the other, but really needs to be both. In order to do that, that means care is available outside just 9 to 5, Monday to Friday. It means after hours and weekend care. It also means people wanted to see a choice of virtual and in-person care, and have that virtual care be integrated into in-person care and ideally used in a way that enhances equity and access, particularly in remote and rural communities. The third standard speaks to this idea of people we talk to wanting the system to be focused on wellness and not sickness. Everyone's primary care team should be connected to community and social services that together support their physical, mental, and social well-being. So this means that primary care needs to work more upstream and really address some of those social determinants of health, including housing and education, income supports, things that we know help keep people well. The fourth standard was really born out of people's frustration that they weren't able to access their own records. Now, many anecdotes of why that was a problem and how that was a problem. But suffice to say that the fourth standard is that everyone should be able to access their healthcare record online and share it with their clinicians and with their caregivers. The fifth standard is that everyone receives culturally safe care that meets their need from clinicians that represent the diversity of the communities they serve. So that means, care that's free from racism and discrimination, free from xenophobia. It means that primary care looks after the full range of needs, including mental health and addictions and gender affirming care. That it's not that primary care physicians or a practitioner should be able to choose, oh, I only give this kind of care. But when somebody goes to primary care setting, they should be able to get all of the services that they need in language and accessibility formats that actually meet their needs as well. And if we really want to create a culturally safe environment and redress past instances of racism and discrimination, past and present instances, I should say, then we need to have a workforce that actually represents the diversity of the people that the primary care team serves. In many ways, the sixth and final standard is perhaps the most important, because I do feel like if we get that one right, the rest will hopefully fall into place. And that sixth final standard is that everyone receives care from a primary care system that is accountable to the communities it serves. So I want to unpack that one a little bit. And I've added some language here from our report to kind of help to do that. But just to say that there are multiple elements of this accountability. One is that we're transparent and accountable around how the system is performing. So that people can see, okay, how does our primary care system compare here in British Columbia compared to that in Manitoba or Quebec or other countries, so that they'd be able to see, okay, what are our investments that we're making and how are those investments panning out? Accountability also means that people are involved in the governance and decision-making in healthcare at the local level, but also provincial and national levels, that they have input into what services are being delivered, how they're being delivered, but also the policy and the measures that are being used to evaluate whether the services are working or not. And another element of accountability is ensuring that funding is commensurate with the community's needs. A last element I'd say of the accountability relates to our systems supporting patient education and empowerment. We heard over and over again how grateful our participants were for this process, because they learned so much about what was to them prior to this really much of a black box. How does healthcare work? They had so many questions that they wanted answered. And they wanted all people to be able to have access to that kind of information through public education and empowerment about, for example, how to navigate the system and how can people look after themselves and take more ownership to support their own health. And I'm looking forward to hearing from you kind of your own views around what this accountability would mean and what it should look like and whether this standard resonates with you. I wanted to go a little further on this last and sixth standard to say, I think in the report, we also provide a number of potential actions that governments can take. Now, these are actions that a lot of our advisors have pulled together based on kind of what we heard from patients and the many reports that we had published. But these didn't all necessarily come right from the patients, but they support the direction in which the patients wanted to see us move. So the first is this idea is having a primary care charter of rights and an ombudsperson, so people know where to go if there is something wrong in the system. We know that in some provinces like my own in Ontario, that we actually do have a patient ombudsperson, but actually primary care is not in the remit or the scope of that ombudsperson's job. Yet at the same time, over the last year, like 25% or so of the complaints to the ombudsperson were actually around primary care, which I think demonstrates that the system is not working and that people do want a place in which they're able to share their complaints. Part of accountability, as I mentioned, is public reporting. Interestingly, it's really hard to actually find public reporting on primary care at a provincial level. The only province we were able to find that on a current basis was New Brunswick. And I think this is something that we're really pushing all governments we're meeting with on, because I think it is something that's low-hanging fruit. We mentioned public education around health system navigation, and then of course, community governance. And I'm really looking forward to hearing more from our community health center colleagues, because The patients in our panel in BC in particular, for example, they were really taken by the community health center model. They wanted to actually see that model taken up and spread throughout the province. And one of the appeals of that model was the fact that it's community governed. And then I mentioned this issue of funding that really needs to be there if we want to achieve the vision of community accountability. So I've left my remarks fairly short. I urge you to go to our website, and I'll put the link in the chat. We have 16 reports in addition to this final report that you can kind of do deep dives in, including the separate reports for each of the BC provincial panel, as well as the 2 community roundtables that we had. So take a look at our website, and I'd love to get I'm going to spend some time over the next bit taking a look at the comments that are coming through the chat, and look forward to your reactions and questions.
Thank you so much, Tara. And yeah, I encourage everyone to use the chat to have your comments and questions, and give some feedback to Tara's questions about what we think is important about community governance and accountability. And next up, I'm gonna invite Catherine from the BC Association of Community Health Centers to share with us. I've given her the difficult task of explaining community health centers in 3 minutes. So Catherine, thank you for accepting the challenge, and go for it.
Hey, thank you, everyone. We at BCatch are really honored to be invited to come and share in 3 minutes what Community Health Center is. So I will start first by acknowledging and being grateful for joining you today from the stolen lands of the Coast Salish people, in particular the territories of the Squamish, Tsleil-Waututh, and Musqueam people. As you can see, we also acknowledge that we are trying to advance health in the colonial context in all the unceded lands in BC. And Community Health Center. So in a very short form, I would like to highlight the 5 principles that we use to denote a ministry as well as our association recognized community health center, while acknowledging that there are a lot of other health models that call themselves community health center in BC, and they are providing much needed services for their community. Those ones might be run by health authorities and other organizations, but a lot of times these other models, what they are missing is what Tara has mentioned, is that community governed and community-led component, right? And we're all trying to do our best for the community. That usually is what distinguishes our model versus the other model. So our model, first and foremost, strive to provide team-based care, interdisciplinary primary health care that includes a whole spectrum of healthcare professionals that range from family physicians, nurse practitioners, all the way to cross-cultural brokers, community health brokers, Indigenous worker, and so on. And we try in Community Health Center, tries to integrate primary care, first and foremost, together with all other forms of care that's required by the community. So that oftentimes could look like social care and community care, health promotion, and care that support community well-being. And this is the most important part that we're going to discuss today, is that it's community-led and governed. I won't go into details because I'm sure Barbara and Masoud will be able to talk about that way further from their perspective. And another key area that our Community Health Center strives to do is to address that social determinants of health, because we all know that that is a key component to ensuring a health and well-being for patients and community, and that our Community Health Center are also required to demonstrate commitment to health equity and social justice. So you're seeing that some of our Community Health Center provide support to particular population groups or groups of population. And while some other community health center might be supporting an entire geographical area, however, their attention is always trained on who else in their community that are facing barriers to accessing care and how do we reach out to them. And the current landscape, community health centers have been in BC for over 50 years. I think the first one being the one Barbara is from, Reach Community Health Center. And that one area I want to highlight in this slide is that community health center, because they're trying to meet the needs of the community, tend to be quite heterogeneous in their service model, depending on what the community needs, of course, with a mixture of primary and other care. And that as a result as well, because it starts from ground up, the funding model for community health center is quite diverse. This is good in one way, but not good in a lot of other ways, because we are often facing challenges in sustaining community health centers in British Columbia. So I will move on to the next slide. And the last slide is a little bit of introduction of our association. So we are glad to be around since 2017. Maybe providing that space for community health center that meet those core principles to be together, to work together with each other, to advocate for this model and to create awareness of this model. Currently, we have about 40 plus members, inching closer to 50 actually, and they all range at the different level of development. Some are trying to put out their proposal to get a community health center started. Some already are operational and serving thousands of people and are looking for a funding model that works best for them. And we're working with the Ministry of Health in this area and hopefully other ministries as well. And then there are also another group that actually that came under what is called strategy funded model that the ministry came out with since 2018. So we have about 9 of those. They are receiving a more holistic package of funding, but we still believe at our association that more could be done to make sure that we truly meet the needs of the community. So that's my few-minute presentation, and I look forward to questions for Barbara and Masoud. If you have specific ones as well, feel free to put it in the chat. I'll be happy to answer them or reach out to you to talk about them. Thank you.
Thanks so much, Catherine. Well done with that big overview. So what we're going to do next is hear kind of alternate back between Barbara and Masoud, who are both on the board of their community health centers. And so the first thing that I wanted to ask them each, and maybe we'll start with you, Barbara, is can you just tell us a little bit about yourself, your background, and how you came to be involved on the board of REACH?
Sure. First of all, thank you for the invitation today. It's really a pleasure to be here, particularly with Tara representing the Our Cares program, because reading that final report, or at least a summary of it, was really so impressive and really exciting to see the work that's being advanced there. So thank you. And to everybody that was part of that, really appreciate that. I just want to say that my professional career has been in international development and human rights work and solidarity work. So I worked typically at an international and a federal level, doing a lot of advocacy work with the Canadian government around better international policies, better development assistance policies, better policies for feminist development in various countries. So that work has been my professional life. And at some point in that time, I decided I really wanted to be more involved in my local community and not just looking always kind of outside internationally or even federally. So when I was invited to put my name forward for election to the board of Reach Community Health Center, it really was a good fit with my values, and I had a bit of time. And so I thought this would be a place to devote it. Also, I'm a patient at Reach and have been for quite a few years. So.
Great, thanks. And Masoud, welcome. How about you? Can you tell us a bit about yourself and your background and how you came to be involved with Umbrella?
Thank you so much. First of all, thank you so much for the invitation. It's really a pleasure to be here. My name is Masoud Rahmani. I'm an internationally trained medical graduate with a master from healthcare administration from United States, representing the African community at Umbrella Club board members. I spent most of my life here in primary care, back home in Afghanistan, some other countries in the region, as well as working in the community healthcare in British Columbia. So my nomination, I just put myself as a nominee for the board members and received the confirmation vote from the participants. And that's how I'm advocating for the African community within an umbrella board, which at the end of the day, the African community is one of the communities that we are covering into certain part. Thank you.
Thanks, Masoud. And Masoud, your audio is a little bit difficult to hear. Is there anything you could do to adjust the clarity of your microphone?
Sorry for that. How is it now? I just removed
Oh, that's much better. So I think I understood that you have been involved in primary care for much of your career. Is that right?
I spent most of my period in primary healthcare, yes.
Yeah, and you're representing the Afghan community on the board of Umbrella. Is that correct?
I do represent the African community. I'm an internationally trained medical graduate from Afghanistan and also have master from public health from United States.
What about you, Barbara? Can you tell us a little bit about REACH and share one story of what it's been like to be on the board?
As Catherine mentioned, REACH is we're celebrating our 55th anniversary this year in 2024. And it started obviously as a very small project on Commercial Drive and has grown really in response to community needs and trying to address and support well-being in our community. A large part of the work that gets done at REACH focuses on social determinants of health that was mentioned earlier. I would just say, just to give a quick idea of some of the services and the work that's done there, we have a gender violence prevention program. There's subsidized and low-cost healthcare, dental care, I should say. There's group therapy for people with mental health and substance use disorders. We have several First Nations programs, including an on-site elder who can meet with people one-on-one and also does group work. We have gender-affirming care for trans and gender non-conforming people. We have an urgent and primary care center to try and fill some of the gaps in our healthcare system. And we have a very bustling and very full service team-based medical care. So there are still problems, and you'll see in the chat, there's a few questions about what REACH has been doing, but it is a very responsive community healthcare center. And in our community, I feel like we're very well situated. The quick story I'd like to tell is a couple of years back when our primary funder, which is Vancouver Coastal Health, was trying to impose a change in our funding system from what had been a somewhat flexible funding system for our healthcare clinic to a fee-for-service model. There was great debates on our board about whether the fee-for-service model would negatively impact our values around accessibility and high quality healthcare, as well as equity. And on the board, I think there was some division that some people thought there might become a two-tier system for those that were in the fee-for-service and those that in the other funding model, because people in the other funding model would be people who would be facing barriers according to various socioeconomic standards and other kinds of barriers in being labeled as a highly complex patient, whereas others who were not facing the same barriers might have a better standard of care. And this went up completely against all of our values and our systems. So word filtered out into the community that this funding system, this funding change might be happening. And people came out in droves to our next annual general meeting in order to make a very clear message in opposition to a fee-for-service model, and that the values around equity and accessibility and high quality care to everyone that walked in the door, no matter who or what you were coming, what your concerns you were coming with. And that voice from the community really shaped, again, how REACH moved forward from that. And the board was directed to say no to Vancouver Coastal Health, to go back and try and renegotiate that. And they did. And we still have a funding model today that is somewhat more, as I say, somewhat more accessible or somewhat more flexible for healthcare providers to be able to serve the population in the way that they need to be served, and not simply a fee-for-service where it's a 10-minute visit for one issue and then you have to come back in for another visit if you have a second issue. So that's just one quick, I think, example of how the community has really, it feels, I think, that REACH is part of the community. They feel part of it, and that REACH does respond to the community.
Awesome. Thanks for sharing that story. I guess I'll hand it back to you right away, Barbara. Now, can you name one challenge that you see with this model of community governance for primary care? And in your experience, how do you see that being addressed?
I think that one of the challenges is that community governance is so important, as everyone has already said, because community needs should be central to how healthcare is served, how healthcare is planned for, and the community should be sitting at the table as those decisions get made. Due to structural racism and colonization in our societies, nonprofit boards tend to have a lot of retired white people on them. And retired white people offer lots of things, experience, and time, but I am one of those people, we do not represent the full spectrum of our community. And I think that is one of the challenges that is, I think, front and center for a lot of nonprofit boards. On top of that, legally, we have certain legal responsibilities that we have to fulfill according to like BC Societies Act, as well as Charitable Act federally. And that formal legal structure means that there's a lot of requirements that a lot of people may not be familiar with or may not be as comfortable with as others, such as formal meetings where there's motions and reports and budgets and elections. And so some people feel more comfortable in those settings than others. So one of the things that our board has done in the last few years to try and increase representation and break down some of those barriers, we have done decolonization training for ourselves as board members. We've also put forward dependent care and transit subsidies to ensure that people can come to meetings without those kinds of barriers. We have a more thorough orientation for new board members. We have a board buddies system where you're paired up with someone just so you can ask questions about things you don't understand or you may need help with. We have done more board education on what governance is. We've tried to shift and make less formal some of our board meetings so that people feel more comfortable in them. And we also provide education, as I said, on governance, on financial literacy, as well as on basic healthcare issues and some of what we hear about as a board. As a board, I think we've made some progress on that, but it's definitely a journey and we're still on it. We're right now looking at we're trying to evaluate the impact of some of the measures that we've taken and looking for the next steps that we have to take.
Awesome, thanks. And Masoud, how about you? Can you share some challenges that you've experienced with this model of primary healthcare delivery and the community governance aspect and your time at Umbrella?
Thank you so much. Definitely. So I'll divide it. First of all, I'd like to echo that what Barbara said, and I'll divide my answer in two parts. First, for the challenge, I think the current financial model is not responding to the needs, and I think the lump sum funding model will be a good solution and also a good response to the needs of the community health centers. And when it comes to the challenge at the board level, so I can say the commitments of the members for their time, as well as the sometimes people are new to the board, and obviously they do need the capacity building sessions and also the capacity to be built as well. Thank you.
Thanks. Well, I have so many questions for the two of you and Tara and Catherine as well, but I don't want to dominate too much. So I'm gonna invite the rest of our participants to share some questions. I think I've formulated a few based on some of the comments and themes in the chat to maybe get us going as the questions come in. So feel free to put your questions in the chat, or you can also use the raise hand function if you'd like to just share your question out loud. And I'll try to keep a balance in terms of questions from the floor of raised hands and coming from the chat. Well, I'm going to start with, since we've got a raised hand, I'm going to go to you, Cheryl. Go for it. What's your question?
Hi, I'm a longtime member of a number of health centers, including REACH. I was on the board at REACH, but I'm from the Saskatoon Cooperative Community Health Clinic, essentially. And what I've seen as a co-op activist, because I did some work with the BC Cooperative Association many years ago, around the cooperative model as it applies to social care, not just healthcare, because all of the community clinics that were set up in Saskatchewan, not all of them, but almost all of the 43 that got going during the doctor's strike in 62 were cooperatives. And my issue is both for cooperatives and for not-for-profits. It's a little clearer in a co-op that the members own the organization, but it is not clear in the not-for-profit sector. And I see it working differently, my experience at REACH and my experience in Saskatoon. And so one consideration I want to raise with this group is there needs to be an alliance with people who are doing similar work like this. The BC Cooperative Association and all kinds of cooperative umbrella groups across the country have a big focus on governance education. And in my view, the community associations that are structured as cooperatives have access to that, but not-for-profits don't. And I think that one of the challenges of not-for-profits is lack of a focus on membership, because you then start, and it happens in co-ops too, and it's happening as people age. I used to be one of the youngest. But the problem is viewing the membership or the board as an advisory body to the staff. And that's what happens if you don't have a huge focus on member-led education and so rather than just talk about the model about how we put forth the integrated services, that we actually have all kinds of them across the country, really good models, but the focus has to be on how to keep them rooted in community. Like, that's the second time, Barb, that we had to fight off. I was on the board when we fought off the health region right at the beginning in Vancouver. But you have to keep doing it. And your pool gets really small if you're only drawing from your existing organization, and it doesn't include the people we're serving. Those voices are not reflected in our membership. They're not reflected in our staff. They're not reflected on our board of directors. And I think that organizations like Umbrella, which operate, I live in New West now, I have, gone a long way in that, but I think we have to learn how to do this, and it's never front and center. So I really appreciate this focus. And that was more of a speech, but sorry.
Well, thanks so much. I can feel your passion for membership and engagement in these processes, and I feel that. I wanted to make a kind of formulate a question based off of a comment from Frank Dwyer about seniors losing access to their family doctors as they're retiring, and I wonder if I'm not going to direct this to anyone in particular, but if one of our panelists is willing to share how a community health center model might address that. Like, if you are a patient at a community health center and your doctor retired, what would happen to you? And also, like, what are the benefits to CHCs for people who are aging at home? Does anyone want to take that?
Sorry, the question was what? Sorry, can you reframe your restate the question? I'm
Yeah.
sorry.
So
I'm
for
also- Go ahead.
sorry, so for seniors who are aging, maybe at home, and are losing their family doctors due to retirement now, how would being part of a CHC, what would happen to them if they were a part of a CHC? And I guess more broadly, how do CHCs support seniors who are aging and aging at home?
I can just quickly say that if you were a patient at Reach, and it's not easy to be a patient at Reach, so I want to say that right off the bat, that our waiting list has been closed for several months. Anyway, if you were a senior and a patient at Reach and your doctor retired, that person would be replaced by another physician or a nurse practitioner or a locum that would continue to treat you and work with you as a patient. We also are able, on some limited basis, to do house calls still. So there are a few of our physicians that will still be able to go and visit people in their homes, which is not something we can do often, but sometimes is a requirement in terms of what the patient's needs are and what their situation is. So that would be a brief Reach answer.
Great, thanks. And there was a question in the chat about what's
maybe I could
difference.
just jump in there, Audrey, just to say
thanks,
that.
Tara, go for it.
I think this is one of the most critical aspects, really, of the Our Care standard and report, is this idea that it's not okay for 20% of people in Canada not to have primary care. Like, that is just not okay. And, you know, let's say us going from 77% to 83%, like, that's not good enough. Like, everybody needs access to primary care. And in order for that to happen, we really have to reshift our thinking and really take a full population approach. Because the way primary care works now, and I'm as guilty of it in the organization I work at as you know, other organizations are too, is, you know, we can decide when we open and close our lists, and some people have access and then other people don't. But what we need is almost like a complete reframing to say, okay, well, maybe there isn't that choice actually from teams or providers. Like, the whole population needs to be covered. That's going to stretch some of us. It's going to maybe mean worse care for some people, but at the end of the day, it's more equal care and better care and some care for like all people. And I think we're at that point where we have to really think about how we want to structure things differently so that 100% of people have access. And that's going to need more resources. There's no question about that. In their interim, as we're building towards that, is it going to mean other choices in the middle? So I just wanted to put that out because it's a really serious problem when seniors have a family doctor who retires and has nowhere to go. We're seeing that all across the system now. And it hurts me when someone, you know, anyone doesn't have a family doctor, but particularly those over 65. I mean, that is a really important demographic where you need care.
Yeah, thanks, Tara. And I had I'm seeing some hands up, so I'll go to I guess Grace. I see you had your hand up first, as far as I can see. I'm sorry if I've missed hands that are flying up. Go for it, Grace.
Thank you. Can you hear me? Okay.
Yes.
My concern is, and I'm totally confused now with today. We're working with community healthcare associations, and then what happens with our regional health centers? Like, how are we going to coordinate systems together? Like, I'm not sure how this is operating, because some of this is nonprofit the way I'm hearing it. And so what kind of tool do we have so we work with our with each of our regions? Like, I'm from BC, so we have 5 regions. So can someone kind of clarify that? Because I'm totally confused. I worked in the health system here until I retired. So I understand our health system, but I'm now trying to know how are we going to integrate then with the associations and the community nonprofits. Thank you for taking my
Okay, maybe I'll take that. So, Grace, thank you for that question. And I can see that how this could create some confusion. So I'm Catherine. I'm from the BC Association of Community Health Center. Our association is a membership-based organization, consists of community health center practicing or providing services across BC. And the role is really to do what we are doing today, is to, as a membership organization, how do we support our members? How do we support community who are exploring this model in terms of integration with health planning in the regional area? Every community that are interested in exploring the different models of care and what suits them the most would usually reach out one way or the other. So no door is the wrong door. And then we try to connect people to each other. So Primary Care Network, which is now the regional service planning body for primary care in most communities that have them and some that do not have them. So we work with all the different primary care networks. If they have people there, they're interested in starting a community health center, they will connect these people to us, vice versa for us. If people come to us and then it found out that we always say that first and foremost, you have to get connected to your community health planning network to know what is needed in community so that you don't duplicate services and there might already be resources available. And then you work with your community to see where you want to go next. And our role as an association is to help these community as well as our own members in just navigating those systems and making sure that we are working together. I hope that helps.
Yes, thank you.
Thank you.
So I encourage everyone to look into the BC BCASH, the BC Association of Community Health Centers, especially if you're from a community that doesn't have good access to primary health care, because they do support communities who are thinking about organizing a proposal to have funding for a community health center in their province, in their community. I'm going to go to Frank. I know that maybe I stole your question earlier. So Frank, you go for it. We have 5 minutes left, so I'm going to ask you to please keep it brief so we can maybe have one more question.
Thank you. I'll bring in a new one. I simply believe there should be triage for people who are on the wait list because your life circumstances can change drastically. I've been on the wait list for a doctor for 6 years. During that time, my wife had a catastrophe. She became ward of the province. I'm 82 years old. I was forced to move from Kamloops to Cranbrook. I now live in an apartment. In the past 3 years, I served as her caregiver for over 4,000 hours, 12 hours a day, 7 days a week. I have moderate high blood pressure. I'm pre-diabetic, and I have been suicidal. I cannot get a family doctor. I've also learned that my wife's disease was hereditary. So our family and our children and our grandchildren are all at risk of ALS or frontal temporal dementia, and yet I can't get a doctor. So my point is not to feel sorry for myself, but that our life circumstances change, and when we age, they often change drastically and sometimes catastrophically, and yet you still can't get attention from the system. During my wife's care, I had 5 hours a day to do all my tasks and feed myself for 2 years. If I went to a walk-in clinic 3 times, each time I had to wait for over 3 hours. That's my day gone. No time to eat hardly. So the reality is we need a system that adapts to change. Thank you.
Thank you, Frank. I think I had seen Paula's hand, and I think I'm going to go to you for last question, Paula.
Okay, having worked in healthcare for 55 years and having an experience last Thursday at Vancouver General Hospital Emergency Department, I see that 20%, Tara said 20% of people in Canada do not have primary care. What is happening, since my family member was treated in the hallway for 14 hours, along with many other patients that were treated in the hallway, as well as stretchers in the hallway, that a lot of the 20% may be ending up in emergency, which then really blocks the emergency departments of all the hospitals. And I have talked to people in different provinces that have been in healthcare and have realized that this is one of the issues that is coming up. And so what happens, to the staff that's working? One of the things that I have talked to the staff about on Thursday was that most of them leave because it is chaos. It is a zoo. You cannot get any kind of care in an emergency department that treats their patients in a chair among everybody else and a stretcher. And everything is done there. So that's all I have to say. Thank you.
Well, thank you for sharing. We're going to wrap up in just a couple of minutes. I'm going to invite everyone to, I'm going to let our panelists have a final word as we wrap up. But for participants, feel free to put in the chat kind of your key takeaway from this. I know for me, I'm just motivated to learn about more ways that the public involvement can be resourced and people can be supported to do that. So let's do a kind of a final closing round with our panelists, and thank you again for being here. So for our panelists, what can you I mean, you have any final remarks, but if you need a prompt, what do you hope to see healthcare to look like in 5 years in BC? Let's go with Masoud first. What do you hope healthcare to look like in 5 years?
Well, thank you so much for the question. I think this is a comprehensive question, but I'm going to summarize my answer in 2 parts. First, to have more coverage, especially for the ethnocultural communities, for those that they're new to Canada and do have the language barrier. And also what Frank says was, I can really hear him and was shocking. So to have more family doctors and have more coverage for the patients and also for the newcomers. Thank you.
Thanks, Masoud. Let's go to Barbara and then Catherine.
Thank you. I think it's so important that you spoke up, Frank, and also Paula and any others of you who have been in these nightmare situations. It's really important for all of us to continue hearing these stories. Otherwise, I think we get a bit inured to the fact that it's difficult and it's dangerous and it's just hard to deal with. It's so important to hear from individuals, your stories, because that also motivates me to continue to try and do as much as we can where we're sitting. In 5 years, I would like to see CHCs and other health centers that deal with people and holistically deal with social determinants of health around the province so that people would have access to primary care as well as all of the other services and needs that they can have addressed at CHCs. This means a real shift in funding, and I think that's why the REACH board is motivated to participate in the BC Health Coalition's provincial election strategy to push for better primary care from our provincial government in the upcoming election. Thanks.
Okay, thanks for that plug, Barbara. Catherine.
I would just want to start by saying I am really grateful and honored to be here, and thank you to everyone who have shared your stories and your perspective. I think that helps, like Barbara said, us in our work that we do. It is field that drives us in doing more. And in 5 years, what I'm hoping to see is greater accessibility for primary healthcare in BC, and that maybe for policymakers and everybody involved, the communities and all of us sitting here to have more of a say in how healthcare looks like in our own community, and that there'll be resources provided to provide those integrated healthcare for all community members. Thank you.
Right, and then Tara, do you want to have a final word?
Yeah, I mean, thank you so much to everyone who attended today and the short stories you shared. I think it is unacceptable in a country where we hold the value of everybody having access to care that so many people don't have access to primary care, the front door to the system, and that really needs to change. And I guess where I'll end is, if you haven't done so already, take a look at our website, ourcare.ca. The things you've been calling on and saying today have been reflected by the numerous people we spoke with. You can read our full report. You can look at the standard. You can actually take a quiz to see how your care compares to the standard. But I think one of the most important aspects is actually this aspect of writing to your elected representative to tell them how it is you want to see things changed and sharing the Our Care standard or anything else you want to with them. So we've made this really easy for you to do. You can just put your name, your email address, and your postal code. It'll auto-populate with your elected representatives, and you can go ahead and send that letter. And I would, we have another section on the website called Advocate, and we've put some great resources on there. And so we were encouraging people, in addition to the letter, there's other actions you can take, including, meeting with media or having meetings with your elected representatives. And we've got some great resources that can support you to do all of that. So I think some of what I wanted to share today is just, it feels pretty hopeless and bleak, but we as a collective have a responsibility to really try and make a difference.
Right. Well, thanks for giving us a good action item to end with, Tara. That's a good place to leave it. I want to apologize to those of you who had questions and we didn't have time to get to. We are over time, and I want to be respectful of our guests and everyone's time. So we're going to go ahead and close this. The recording is going to be made available, and please never hesitate to reach out, info@bchealthcoalition.ca if you have an idea or a comment or feedback. We'd love to hear it. And also we'd love to hear your ideas for future themes for the Lunch and Learn series. So I think with that, I will say have a good afternoon or evening if you're elsewhere. Good to be with everyone today.